joining us today. A warm welcome to my presentation. I was kindly invited to present our work, and I'm happy to be in your company today. I'll present how our cancer genetic counseling and testing was set up and where we are now. Because the story goes far back, 20 years back, and we have a strong connection with Vrije Universiteit, and I'm very glad that I have this opportunity today. Well, I am a medical doctor specialized in clinical genetics and public health, and I'm heading cancer genetics clinic at the Institute of Oncology in Ljubljana. For all those who haven't been in Slovenia, it's a 2 million country, so it's a small country. Well, we see ourselves as a Central European country, and with regards to the population that we have, we are having around 5% of foreign citizens. So our cancer genetics clinic is situated at the Institute of Oncology, Ljubjana, and this is a principal national institution for the comprehensive management of cancer. Our clinic is main cancer genetic clinic for the country, and we accept referrals from all over the place, and majority of them come from oncologists, family medicine doctors, and other specialists. We are proud to have everything at one place. So from genetic counseling, multidisciplinary assessment, genetic testing, and later for all those who are positive, we offer personalized cancer screening and prophylactic surgeries when needed. As you know, progress of medical genetics gave new treatment, and lots of treatments are now connected with genetic results. So having cancer genetic clinic in place was very, very crucial at that point. I would like to go a bit in the past, how cancer genetics was set up and how did it all started. And I'm happy that Professor Jacques de Greve is here today with us, since without him and his team, especially Dr. Erik Teugels and Dr. Guido Hulen, who were my mentors and co-mentors back in 1999 when I was in Brussels doing my master's degree in medical and pharmaceutical research. With the help of Professor de Greve later on, I defended my PhD thesis at Vrije Universiteit, and it opened many doors for me. So I'm really grateful to the Vrije Universiteit, to Professor de Greve, to open this door for me. And you will see how important this was. So soon after the discovery of BRCA genes, cancer genetic testing was available for our population, since we cooperated with Vrije Universiteit. And later on, we connected with our research institutions, and also not just in Europe, but with countries around us, and had several bilateral projects like the one that is stated here with Cyprus. I'm really glad that I can say that by 2008, all genetic tests were performed at the laboratory of Professor de Greve. And it was really, really crucial cooperation for us, since two of our molecular biologists went to Brussels, learned the techniques, and implemented tests in Slovenia. So from 2008 on, all genetic tests are performed at our institute. And this cooperation with Brussels gave us really a lot of knowledge and energy and the know-how, because in a way we copied the system that you are having. Since the very first day when we invited people to genetic testing, we had multidisciplinary setting. And first, Slovenian families were assessed in Brussels as well. So by this knowledge, we really gained a lot. We are very proud that we arranged in 2008 that state insurance covered all costs for counseling and testing. Not many European countries succeeded in this. Even now, if you look at our neighboring countries, especially countries that are from ex-Yugoslavia, they still have a problem how to cover the expenses. And as you can see, our state insurance was open, and for us it was very much easier to implement that because we had some results, and you will see later on. First 60 positive families were tested in Brussels. So after 2008, when our testing and counselings were covered by insurance company, we could open even more, and we organized screening for high risk at the institute. So we opened two clinics, one for high-risk breast cancer and one for high-risk gynecological cancers. So at these two outpatient clinics, our positive, our patients that are at high risk can, in a way, perform the screening like big screening programs do for cancer. In 2011, we established clinical pathways and Slovenian guidelines that mainly follow NCCN guidelines from the states. In 2014, we were for the first time faced that we don't have much time to collect the data and to arrange for testing. Our clinicians wanted to have test results yesterday, not tomorrow. So we had to organize a special clinical pathway for testing that is needed for patients in order to get the right treatment. And later on, as you know, since new drugs, PARP inhibitors, were accepted for general use for ovarian cancer, and we are expecting PARP inhibitors to be accepted for treatment for metastatic breast cancer patients and prostatic cancer patients and pancreatic cancer patients. So it was nice that we started already in 2014, and now our clinic is ready for that. In 2016, after an invitation, we joined the European Reference Network for Genetic Tumor Risk Syndromes. And in 2018, we underwent a very strict technical assessment and on-site audit and got almost all points that were needed for a positive result. So we are really happy to be a member of this network. And again, we are now in cooperation with Belgians, which is really nice, at least for me, since we share similar procedures. So it's very good. In 2018, as you know, since new drugs were discovered, we had to start tumor testing, and it was available already in 2018. In 2019, at my department, we started national registry of tested individuals from cancer families. And in this registry, more than 10,000 patients are already registered. And it's a good platform to perform basic research, epidemiological research, and even clinical research with high-risk patients. Just an overview of hereditary cancer for those who are not familiar with that, who do not work every day with hereditary cancer. As you know, cancer develops as a result of an accumulation of genetic pathogenic variants, but not all cancers are hereditary. So vast majority are sporadic, and somatic pathogenic variants occur during our life. But in some cases, they are inherited, and you can find them in all cells in your body. And these pathogenic variants cause cancer predisposing syndromes. So when do we suspect a hereditary cancer syndrome? Whenever there is an early disease onset, like 10 to 20 years earlier than you would suspect a certain cancer diagnosis. So it's very good to know a bit of epidemiology of cancer, what causes cancer, specific cancer. You will find multiple cases in a family, or you will find more than one cancer in one individual. Cancers are occurring in both of pair organs, like eyes, kidneys, or breasts. And when there is more than one childhood cancer in siblings, then you should think of hereditary cancer syndrome as well. Then when you see a man with breast cancer, or so cancer that occurs in the sex that is not usually affected with that type cancer. Sometimes specific pathological findings make you think that it might be hereditary, like diffuse gastric cancer or medullary thyroid cancer. Majority of hereditary cancer syndromes are inherited in a dominant inheritance pattern, and genetic testing for these pathogenic variants has an important place in the management of these individuals. So when we think about autosomal dominant inheritance, we have to know that it can be transmitted from both parents, male or female, and patients' first-degree relative have a 50% risk of carrying the same pathogenic variant. This is just the list of many different hereditary cancer syndromes that we see at our clinics. With two syndromes that are presented, the most prevalent, it is hereditary breast and ovarian cancer and Lynch syndrome and polyposis. So later on, I will talk more about these two, since you would suspect that 1 in 400 in a population would carry either BRCA1 or BRCA2 or pathogenic variant in a gene that is connected with Lynch syndrome. So whenever you have a pedigree, a family tree, we should make a differential diagnosis. So whenever we see cancer in a family, we ask patients with which cancer their relative was diagnosed and at what time. And that helps us to think of what kind of hereditary syndrome could be present in a family. We forget a lot of time to ask the broader audience, those who are not dealing with cancer every day, when do we forget to suspect hereditary cancer? It happens when you have a patient with common cancer, like breast cancer or colon cancer. And if you don't ask a person about a family tree, you would miss a hereditary cancer syndrome as a cause of that particular cancer in your patient. And we know now that more than 90% of carriers are not diagnosed, they're missed. they're out there and they don't know if they're higher risk for cancer, which is really bad because for majority of hereditary cancers that we know at the moment, we have screening strategies and prophylactic strategies to either make an earlier diagnosis or even prevent a person from cancer. So current strategies to identify carriers of germline pathogenic variants that predispose for cancer are either via relative with cancer or via tumor testing. Whenever you find a pathogenic variant in a tumor, it could be either inherited or somatic. So with a genetic test for germline, you can see whether there is a syndrome in a person or not. And in some population, when the populations where there are founder mutations, these populations, like Ashkenazi Jewish population, may opt for population screening for these founder mutations. So at the moment, cancer susceptibility genetic testing cannot be used as a screening test for general population. It's not used as far as I know. And in clinical setting, it is one component of a comprehensive cancer care, either as a risk assessment tool or as a therapeutic target plan. Yeah, when searching whether anyone already has genetic population genetic testing in place, I did not find any country that would opt for that, but there were many research performed, and majority found cost effectiveness, that it would be of a benefit for a population. But on the other side, since genetic counseling is needed, I think no country can face the workload that comes in parallel when you want to do this testing in the right way. As you know, in majority of developed countries, after a referral, you should have a pre-test counseling, and a person should provide an informed consent for test, and disclosure of results should be performed in person, at least for those who are carriers of pathogenic variants that predispose for cancer. So what is important for a patient, a journey starts at that time when they receive a positive result. And we are really taking care of these individuals. So we are providing them follow-up and screening for particular hereditary syndrome. It's very important to present genetic language to lay population, to population from general public, and we have issued many leaflets and small booklets for people who are coming for counseling. So first contact with cancer genetic counseling service is usually via phone or an email. And what we do, we send them these information leaflets and ask them for family tree, for all data that we need to draw a nice family tree. When we get the data from people that are referred to us, we verify cancer diagnosis in our cancer registry. Our cancer registry is the oldest in Europe, with obligatory reporting to the cancer registry. So we have all cancer diagnosis since 1950. And it's important because in this registry, you get information where the person was operated. So we get information of pathology lab, and we can ask for paraffin embedded samples as well for deceased patients in case we don't have someone with cancer that we would like to test. So it's a huge advantage that we have, and I'm really glad that I can say that for our country. Yeah, like I said, we copied the system from the department that was headed by Professor de Greve at that time. And since the first lady that was tested in a research setting at that time, this family was at that time already assessed in a multidisciplinary team. And we have now quite a big group. Our multidisciplinary team is now consists of 20 members that see each other once per month, every first Tuesday, and we discuss new families and we discuss special cases, what would be the optimal way to move forward. So when we discuss with patients about testing, we are discussing the risk of having a mutation, and we are discussing the risk of cancer after the test results. So we have to take our time to explain to the people who opt for testing what would happen to them in all possible scenarios. So for positive and a negative result. And we have to be very, very clear about limitations, that not all mutations are detectable, maybe not even all genes are discovered yet, that we may find variants of unknown significance, and that for some of them we might never know what they mean, and that negative result is fully informative only if a deleterious pathogenic variant has been identified in a family, and that results may be important for their offspring. So lots of limitations in a way that some people might not like to share these informations with other family members. When we look at the two most common and most frequent hereditary cancer syndromes, of course, we have to start with hereditary breast and ovarian cancer. Since the discovery of BRCA1 and BRCA2 genes, many other genes were connected to higher risk for breast cancer and ovarian cancer as well. And even though it's now almost, we are in 2022, we know that we don't know everything. So half of the families that we assess are still not resolved. So we have to find a way how to resolve these other genes or maybe other modifiers of risk for breast and ovarian cancer. Just a quick overview about BRCA genes. So they were sequenced in 94 and 95. They both predispose for breast and ovarian cancer. And with BRCA2 carriers, we must not forget male breast cancer risk and prostate cancer risk. So it's important for both genders to come for testing. As you see, the risk at 80 for breast cancer is almost similar, but BRCA1 carriers, they develop breast cancer a bit earlier. And the cumulative risk for BRCA1 and 2 carriers for ovarian cancers is a bit different. So for BRCA1 carriers, the risk is a bit above 40%. And for BRCA2, it's almost half. Anyway, it's still very high, and it's important to offer carriers the right surveillance and prophylactic procedures. So in the era of next generation sequencing, we know that we are not discovering just BRCA1 and 2 genes, but there are several genes that we connect with breast and ovarian cancer. And here's our gene panel. So we are using TrueSight hereditary cancer panel. And when we think of let's say a family that could have hereditary breast and ovarian cancer, we test for these genes. Of course, in the lab, they might find some incidental findings in other genes, and they usually report that. They don't report that if a patient says, no, I just want to know for these genes. So we do listen to patients, but majority would like to know for incidental findings as well. So for tumor testing, we are using through site panels as well, and we are performing all modern procedures that are used nowadays, especially homologous repair deficiency status is now a big question. What's the right way, how to assess that? And this is the thing that is now a main research at our molecular biology lab. So this is how our families look like. This is a lady with ovarian cancer. She reported cancers from both sides, her mother and her father. And later on, we detected BRCA1 pathogenic variant that was inherited through her father. Here you see breast cancer at 25, ovarian cancer at 45, and grandmother with breast cancer at 87. Well, for her, we are not so sure that she could be a phenocopy. She developed breast cancer really late, just to get an impression. As I said at the beginning, we are mainly following NCCN guidelines in our cancer genetic assessment. But still, we are testing all women with breast cancer that develop breast cancer before 45, or all women with breast cancers that are triple negative or bilateral regarding the age of onset, and whenever there are at least 2 breast cancers with at least one that was discovered before the age of 50. As you have seen before, it's a high, for carriers, we know that it's a high breast cancer and ovarian cancer risk. And we have several preventive measures that are evidence-based. And with these measures, we know that we achieve our goal, that our ladies, if they follow these preventive measures, they can, in a way, come close to the risk of non-carriers, especially if they opt for surgical prophylactic surgeries. Yeah, and it's important to say that for our BRCA and other positive patients, we offered surveillance at our clinic, and we operate in the same way as national breast cancer screening or other screening for cancer that is population-based. So we give dates for follow-up in advance, so women don't miss this 6 months period when they have to come. In 2010 already, there was one big publication that with the preventive measures that we are offering, they are really prolonging the lives of our carriers. So it's important to say now in the era of establishing new cancer screenings, as you know, European Parliament approved 3 cancer screenings for breast, for general population, for breast, colon, and cervical cancers. And now it's a huge debate in Europe whether we should screen for lung or gastric cancer as well, and some other cancers. And I'm always saying it would be really great to instead of starting something that's not evidence-based, to start screening for high-risk population in a manner as big population screening programs work. So I hope that in the near future, we will achieve that in Slovenia, so that everyone that is a genetic tumor risk patient will be involved in a program that is controlled by the country in a way. So sometimes we face the problem. Let's say we have a patient with no cancer, and our patient has relatives with breast cancer. We don't detect any mutation. And the question is this person still at high risk or is not at high risk? And as you know, for breast cancer, there are several other risk factors. And what we did in Slovenia is we implemented Slovenian population breast cancer risks into a Tyrer-Cuzick model. So the curves that are written here are Slovenian curves. And this program is very nice because with this you can do two things. For primary level clinics, it's really good because in like 5 minutes, a woman knows whether she should go for genetic testing due to probabilities of carrying a mutation. And on the other hand, you know how to counsel how this lady should be screened and from what age on. So we put lots of effort in that because we know that our age-specific rates of breast cancer per 100,000 is a bit lower than it counts for other Western European countries. So for us, it's not safe to use the models that are available online. And we all know that whereas the future, we should, for the unsolved familial cases, there is a thought that these cases might be due to polygenic inheritance patterns, so not non-Mendelian, and several countries already have some research projects on polygenic risks, and they are developing risk scores, and these risk scores might be already used in these programs that we are using, are either Tyrer-Cuzick or CanRisk. CanRisk is even better. It involves not just breast and ovarian cancer, but also pancreatic and prostatic cancers. It's important that this program offers us to put the data on hormonal receptors of breast cancers, and also it involves calculates the probability of other genes, not just BRCA1 and 2. This program is a bit time consuming, so it's not meant for primary level. It's good for genetic clinics. So we know now that genetic testing provides the key for accurate cancer risk assessment, for effective genetic counseling, for appropriate medical follow-up, for cascade testing whenever we find a positive, and for patients that are treated appropriately to their genetic status. When new PARP inhibitor was implemented in Slovenia in a compassionate use in October 2014. After 2 years, we just checked how many ladies with ovarian cancers that were referred to us are positive, and we detected really a huge mutation detected rate at that time. It was 36%. Later on, it fell a bit. We are just analyzing this data, so I cannot present it right now. But we know that here a majority of referred patients were high-grade serous ovarian cancers, and we know that in Slovenia we might harbor a few recurrent mutations, and we suspect that our prevalence of BRCA1 and 2 carriers is a bit higher than reported in the literature. Since when a few years ago we assessed only breast cancer patients that were referred to us, again among triple negative breast cancer patients, it was again very high mutation detection rate for, this is not just for BRCA genes, but for other genes in a panel. So we do hope that in the near future we would have resources to assess prevalence of mutations in these genes in Slovenia. We will see. Just briefly, it's nice to go through Lynch syndrome as well, because it's a syndrome that is according to the literature, is very prevalent in the population, but in majority of times it's missed. It accounts for 2 to 3% of all colorectal cancers, and 5 genes are responsible for this syndrome. And regarding to the gene, there are some other cancers involved, not just colorectal, so the penetrance depends on the gene involved. For MLH1, it's the highest, and it is estimated to be as high as 60% of probability of developing colorectal cancer if you're a carrier of MLH1. With this syndrome, we follow NCCN guidelines too. So we offer patients who are positive regular colonoscopies, and whenever needed, also surgical involvement. So this is one of our families. You see here a lady with endometrial cancer and cancer of colon. She developed endometrial at 48 and colon cancer later on at 65. She reported that she has a sister, the same with endometrial cancer at 41 and colorectal cancer at 60, and their mother died of colorectal cancer. So this family was MSH2 positive. As you see, the surveillance is very important, and genetic test is helping us to classify, to stratify persons according to the risk. And according to the risk, we advise interventions later on. As I said before, we have a register for hereditary cancer. And I will just go quickly through our results because we are just preparing our first report. Here, it's the year of 2020, so the COVID year. As you see, we were operating normally. Majority of patients were referred from oncologists and then gynecologists and general practitioners. Majority of patients that we assessed were patients where hereditary breast and ovarian syndrome was suspected, and the quarter was for Lynch syndrome and polyposis syndromes. This is interesting to see how we developed, this is for each year, how many new families were discovered from 2001 on. And I like this slide even more because this is our prevalence of hereditary breast and ovarian cancer families. In 2020, there were 902 families with syndromes connected with pathogenic variants in these genes. And as you see, the first 60 families that were positive were tested in Brussels. And I'm proud to say, whenever I go to lecture abroad or in Slovenia, I'm really glad that I can say that, because that gave a huge start-up point for us. So we could show our results, and the state was listening to us. Well, for Lynch syndrome, I think is universal. Lynch syndrome is missed, and as you see, numbers are much lower. And when we see in 2018 and 19, here was a big difference. Why all pathological labs started immunohistochemistry. They tested tumor samples for, as you know, tumor staining for all 4 proteins that are coded by mismatch repair genes. And through tumor testing, we are now receiving patients and their family members. So at the moment, we are having 54 families with Lynch syndrome. Yeah, and I will just go through a few slides. These are my last slides, a few of our publications. And I'm glad because this is the first publication that I had. It was the data that was gathered for my master's. And with the help of Professor de Greve and Dr. Hito Huln, Eric Teugels, I was taught how to write a research article. And we were really surprised at that time because from out of first 7 tested families, in 3 we found a BRCA2 splice site mutation. Later on, we also made a publication that it is a founder effect. So this mutation is present very frequently in our families. It's interesting that some samples were tested in other places, and this mutation at that time was not detected, let's say in England. And it was a huge discovery. I can say that later on this mutation was reported in Italy as well, but as you know, we are bordering Italy, and I guess that many of Slovenians just moved to live there. So in 2008, this is our second common article that we published with Professor de Grave's team. Later on, we discovered it's not just this BRCA2 founder mutation, but there are some other mutations that are occurring frequently. And these 5 that we present here accounted for 67% of all mutations that we found. So it was at that time, as you know, NGS was not in place. So testing, screening for mutation was time consuming, and knowing that you're having in a population recurrent mutations was a huge advantage because we developed quick tests to test for these founder mutations. This BRCA2 founder mutation was later on assessed by my colleagues and me. We analyzed all male breast cancer patients, and in 25% of them, we detected BRCA2 and BRCA1 mutations. And it's really interesting that in 9 positive, this BRCA2 variant was detected. And it looks like it predisposes for male breast cancers. And we were trying to connect genotype with phenotype in this article. Another common publication with VUB was geographical distribution of Slovenian BRCA families that are recurrent. And it was a nice insight how, even though I'm coming from a small country, some families did not move a lot. So we, here in this article, we in a way proved or tried to prove that there were some clusters of different families that might have a common ancestor. And I'll finish with 2 publications that we published recently. One is we wanted to assess what is happening with our ladies that opt for prophylactic adnexectomy. And it was interesting to know that out of 155 consequently operated high-risk asymptomatic patients, we detected 9 occult ovarian cancers. 4 of them were in situ tubal cancers. And by this knowledge, we proposed that maybe in Slovenia we opt for preventive ovarectomy a bit too late. So it was a very important information for us, as well as when comparing with others in the literature, our detection rate of occult ovarian cancer was similar to other studies. Recently, again, similarly to ovarian cancer prevention, prophylactic surgeries, we wanted to see how many ladies opt for a risk-reducing mastectomy. What's the uptake of unaffected BRCA1 and 2 carriers? And we discovered that out of 346 ladies, 87, that represents 25%, opted for risk-reducing mastectomy at average age of 43. And this is an important information when we discuss with ladies how is it, how other ladies decide. As you know, when you are having a young BRCA positive woman in front of you, you say that she has two possible preventions, either primary, so operation, or secondary, which is screening for earlier detection of breast cancer. And what was interesting here too was that we detected in 5.7% occult breast cancers when we operated these ladies. So these cancers were not detected by screening methods, so MRI and mammography, but were detected after operation. These were small cancers, but still it's important to know that whenever a woman opts for preventive mastectomy, you should know that you might expect breast cancer at that time as well. Well, with this article, we wanted to see whether we had Angelina Jolie effect as well. So after 2014, when Angelina Jolie went public with her decision, the uptake of preventive option, prophylactic surgeries was higher, and you can see that in this graph. I cannot find the mouse now. Here, you see here. If you see the average here and the average before 2014, it was a statistically proven difference. Yeah. So what's the future? Where are we heading? I discussed already about genetic screening that could be population-based. I think no country is prepared for that if we want to do it in a proper way with genetic counseling. But many research is ongoing, and perhaps we will find a nice clinical pathway for that. So one of my colleagues said, do I really have to wait that someone from my family gets ill in order to be tested? So in a way, yeah, it would be great that adults can choose for genetic tests and see whether we are in this group of high risk or not. But I think we are not there. We should wait for research results. But what we are seeing here that it's needed and could be on place is the personalized cancer screening for genetic tumor risk syndrome patients. So I hope this will evolve in a way that will be possible for every patient that is a carrier of pathogenic variant that predisposes for cancer will be assessed whenever, wherever you go in Europe, at the same way in an organized setting with quality control. So it's very important. Yeah, and let's say one cannot do all these alone. This is back 20 years ago when I was still in Brussels and I came to Slovenia and we were assessing families. So the team of surgeons, radiotherapists, molecular biologists, psychologists, genetic nurse were on place at that time. And now we are all older and we grew. So even these pictures are all already at the moment at my department we are 20 and at the lab, I think there are close to 30 already. So it's evolving, and it's every year, I think more and more oncologists will need our services. With this slide, I would like to end, and I hope it was of interest for you, and I will be happy to answer questions.